All right, let's start with the diffuse proliferative glomerulonephritis. In DEP, in DPGN, diffuse proliferative glomerulonephritis, it is often due to SLE. So SLE patients are more likely to have a diffuse proliferative glomerulonephritis. I think wire lupus. Okay, so DPGN and the membranous proliferative glomerulonephritis often presents with nephritic and nephrotic syndrome. So this is one of the things that we talked about that's going to have both the features. You will have both features of nephritic and nephrotic features. For example, you'll have proteinuria greater than 3.5 with hematuria, full-on hematuria. Okay, so let's talk about the light microscopy. In light microscopy, you're looking at wire looping of the capillaries. Looking at picture D, you have the wire looping. Look at just this thing. It looks like there are wires looping. Look, wire looping. Wire looping in the capillaries of the capillaries. And then you have this. If you were to look at it in an immunofluorescence, you will see granular casts. Okay, you will have a granular immunofluorescent. Electron microscopy will show you subendothelial, sometimes subepithelial. I mean, again, think about it. Either you're here or you are in subepithelial depositions or intramembranous, even intramembranous deposition of IgA-based immune complex, often with C3 deposition. So IgA, IgGs, and C3 immune complex depositions. Again, this was the hallmark of nephritic syndrome, being an IgGM, GRM, and with C3 deposition. That was the hallmark, and leading to decrease in complement system, leading to hypocomplementemia, right? So now, important thing in here is glomerular. So let me just write this in a different pen. So glomerulonephritis with SLE. Sign symptoms are arthralgias, oral ulcers, cytopenias. Shows SLE complicated by lupus nephritis. So patient normally would have an SLE complicated with it's also called SLE nephritis or lupus nephritis. It occurs due to deposition of your DNA, anti-DNA immune complex within the glomeruli, leading results in type 3 hypersensitivity reaction, which then leads to glomerular injury and in decrease in renal function. It can deposit anywhere. They talked about in either in subepithelial or intramembranous, which is also called mesangium. So basically, with SLE, whenever you see SLE relating to nephritis, could be nephritic or nephrotic. Think about DSP, DPGN. Okay, so that's all we have. One important thing you have to remember that in SLE you have this double-stranded DNA, right? Double-stranded DNA antibody, right? That's what you have in SLE. So same thing. Now we have these same antibodies coming and depositing within the subendothelium, subepithelium, or in the mesangium, leading to nephritic or nephrotic syndrome. Very important with SLE. Moving on with the Alport syndrome. Alport means 4. We have talked about it. 4 is a type 4 collagen mutation. When you have the type 4 collagen mutation, it leads to glomerular basement membrane alterations. What alterations are we looking for? We have thinning and splitting of this of a glomerular basement membrane, because it does not have that type 4 collagen now, right? It is most common X-linked. Dominant eye problems will be seen, example retinopathy, because we need type 4 collagen for all of this. So basically, when we don't have type 4 collagen, whenever organ we need type 4 collagen, will be out like basement membrane, retinopathies, anterior lenticonus glomerulonephritis, SNHL, can't see, can't be, can't hear a B. Okay. Uh, Sensorineural hearing loss because type 4 is out. So these are the things we will be seeing with Alport for type 4 collagen. So let's talk about something that what else? Now here, importantly, on electron microscopy, you have this basket weave. Okay, basket weave with laminated appearance. If they have mentioned laminated appearance on the glomerular membrane, so appearance due to irregular. Why do we have basket weave? Because irregular thickening and longitudinal splitting. We talked about it, splitting and thinning. So it's a splitting and thinning and longitudinal splitting of the glomerular membrane. On immunofluorescence, we see it's a negative. It's an irregular deposition of IgGs, Ms, or C3. May be observed later on electron or light microscopy. You have irregular thinning and thickening and splitting of glomerular membrane. So because we don't, the whole point, all they're talking about is basically crap, but it's type 4 collagen is out, so all these organs which need type 4 collagen will be defective. So because of the basement membrane is going to be defective, you have thinning and splitting because you don't have type 4 collagen, and leading to basket weave. Okay, so that's what we have for the Alport. Let's continue with membranoproliferative glomerulonephritis, MPGN. Membranoproliferative glomerulonephritis. It's a type 1, maybe secondary to HBV, Hep C, HCV infection. Type 2 associated with, so you got two types. Type 1 is associated with secondary to HBV, HCV, and type 2 is associated with C3 nephritic factor. What C3 nephritic factor is going to do? It's going to stabilize C3 convertase. When you stabilize that C3 convertase, now remember that you have C3 and C3 forms C3A, right? And also C3B. And which enzyme makes it active? This thing, C3 convertase coming from this place. So when you have C3 convertase all the time present, so all of your C3s are going to be in active form. So when they are in active form, leading to persistent complement activation and eventually decrease in C3 levels. Okay, so that's the type 2 with the nephritic factor, C3 nephritic factor. Now you have the in your light microscopy, you see mesangial ingrowth, glomerular basement membrane splitting, TAM tract, very important, TAM tract appearance. Looking at picture E, you have the TAM tracts. Let me zoom in. How do I do this? Okay, look at those TAM tracts. TAM tracts. Formation of TAM tracts. Why do we have formation of TAM tracts? Because it has deposition within the subendothelial immune complex deposition or intramembranous deposition, also called dense deposit disease, leading to formation of these TAM tracts. So let me just illustrate that one. So if you have the deposition here and here and here, so now you have the TAM tract appearance. So that's the TAM tract. Anyways, yeah, that's with the membranoproliferative glomerulonephritis. Let's move on. What do we have next? Finally, let's do the next one and talk about nephrotic syndrome.